Hello everyone, and welcome to this presentation on neonatal hypoglycemia. I am the Docsaab, and today we will be covering a critical overview of this condition for healthcare professionals. Neonatal hypoglycemia or low blood sugar in newborns is a common and potentially serious issue that requires prompt recognition and management to ensure optimal outcomes for our young patients. We will dive into its definition, clinical signs, underlying causes, diagnostic approaches, treatment protocols, and crucial consideration for long-term neurodevelopment and safe discharge. Let's start with foundational understanding. Neonatal hypoglycemia is precisely defined as a low level of plasma or blood glucose in the neonate. It is important to remember that shortly after birth, healthy term newborns naturally undergo a transient physiological fall in blood glucose concentration. This typically reaches its lowest point or nadir between 60 to 90 minutes after birth. Subsequently, as the neonate adapts to extrauterine life, these glucose levels usually rise back to above 60 mg per deciliter by approximately 4 hours of age. An interesting point to note is the role of breastfeeding in this metabolic adaptation. Breastfed infants may actually tolerate low blood sugar levels because of the availability of the bioavailable alternate fuels, such as ketone bodies, which help facilitate their metabolic transition. Understanding this physiological curve is absolutely crucial for guiding our clinical decisions and distinguishing normal adaptation from pathological hypoglycemia. Recognizing the signs of hypoglycemia is paramount, though these can often be subtle and non-specific, making vigilance essential. We categorize these clinical manifestations into two main types. First, adrenergic signs, which represent the body's acute stress response to low glucose. These include rapid breathing, known as tachypnea, as fast heart rate or tachycardia, poor suck, and poor feeding, which can be early indicators. Pallor, indicating reduced blood flow to the skin. Temperature instability, where the infant may struggle to maintain warmth. And sweating, a less common but significant sign. Second, we have neuroglycopenic signs, which are particularly concerning as they directly indicate that brain is not receiving enough glucose. These are often more severe and include lethargy and hypotonia, meaning the infant is unusually sleepy and floppy, apnea or irregular breathing efforts, which can be life threatening, cyanosis or bluish discoloration of the skin due to lack of oxygen, and in the most severe cases, seizures. It is extremely prudent to prevent recurrent and persistent hypoglycemia, as these are strongly associated with adverse long term neurological outcomes such as seizures, as well as impaired visual motor skills and executive functional deficit observed in children at 4 to 5 years of age. While there is no clear definitive association between single episode of asymptomatic hypoglycemia and its treatment leading to poor neurodevelopment, the potential for harm for recurrent or severe episodes necessitate our proactive and diligent management. Defining neonatal hypoglycemia is actually highly controversial, and there is significant lack of universal consensus at present. Instead of single, universally accepted numerical cutoff, we primarily rely on operational threshold cutoffs. These are specific glucose levels that indicate a need to intervene, thereby providing a reasonable margin of safety. For symptomatic neonates, intervention is typically warranted when their blood sugar levels falls below 40 mg per deciliter. For asymptomatic cases, the threshold are is specific to account for the infant's physiological maturation. If the infant is less than 4 hours of age, a threshold of 25 mg per deciliter is considered critical. Between 4 to 24 hours, it is 35 mg per deciliter. From 24 to 48 hours, it is 45 mg per deciliter. And if the infant is over 48 hours, the threshold is 60 mg per deciliter. It's especially important to note that there is a paucity of specific literature on preterm neonates less than 34 weeks of gestational age. For this particularly vulnerable group, it is generally considered prudent to maintain blood glucose levels above 50 mg per deciliter to minimize potential risk. The causes of neonatal hypoglycemia are diverse and can broadly be categorized into two main groups: factors leading to decreased glucose production or insufficient glucose stores, and factors leading to increased glucose utilization. On the side of decreased production or stores, we often see prematurity, where infants haven't had enough time to build up glycogen reserves, intrauterine growth restriction, which can compromise fetal nutrient supply, delay feeding post birth, endocrine deficiencies like growth hormone or cortisol deficiency, and more complex N-bore errors of metabolism. Conversely, factors that cause increased glucose utilization includes infants of diabetic mothers who often experience hyperinsulinemia due to maternal glucose levels, large for gestational age infants who may also have hyperinsulinemia, systemic issues like sepsis, which increases metabolic demand, asphyxia, which can deplete glucose rapidly, hypothermia, which boosts metabolic rate, polycythemia, leading to increased glucose consumption by red blood cells, hyperinsulinemia from other causes, and even maternal use of certain medications like beta blockers or oral hypoglycemic agents, which can cross the placenta. Identifying the specific underlying cause is absolutely crucial for implementing the most effective and targeted management strategy. Regarding screening and testing procedures, it is vital to emphasize that testing for hypoglycemia is warranted only for at risk neonates and is generally not indicated for healthy term newborns. For initial assessment, point of care testing using reagent strips is typically employed as it's rapid, convenient, and cost effective at the bedside. However, a critical caveat is that blood glucose reading obtained via reagent strips can be approximately 15% lower than actual plasma glucose levels. Therefore, if a strip test indicates low blood glucose, particularly at levels that would prompt a significant intervention, a formal laboratory sample should always be sent for accurate blood glucose estimation and confirmation. Furthermore, be aware that a delay in processing a collected blood sample can lead to significant reduction in the measured glucose level, potentially by up to 6 milligram per deciliter per hour. An extensive workup for or investigation is specifically indicated for infants presenting with persistent hypoglycemia, defined as low glucose levels lasting more than 72 hours, or for those with severe hypoglycemia requiring a glucose infusion rate greater than 10 to 12 milligram per kg per hour minute to maintain euglycemia. This situation warrants a deeper dive into the underlying etiology. The management of neonatal hypoglycemia begins with a universal care applicable to all infants, regardless of their risk status. This includes promoting immediate skin to skin care to help stabilize temperature and facilitate bonding, keeping the infant warm, and encouraging breastfeeding within the first hour of birth and subsequently on cue. Crucially, it is recommended not to give water, glucose water, or formula unnecessarily, as this can interfere with the infant's normal metabolic compensatory mechanisms. For asymptomatic infants who present with blood glucose less than 40 milligram per deciliter and are less than 4 hours old, the initial management involves starting breastfeeding promptly within half an hour, performing skin to skin care, and intensifying breastfeeding efforts. Their blood glucose should be rechecked before the next feeding. If despite these measures glucose levels remain below 35 milligram per deciliter, intravenous glucose therapy should be initiated. The overarching goal during management is to achieve and maintain blood glucose levels greater than 50 milligram per deciliter. Continuous monitoring is a key. Glucose should be rechecked until 3 consecutive normal levels are sustained. Additionally, for at-risk babies such as those who are small for gestational age, low birth weight, or preterm, final glucose check should be performed once at 24 hours of age to ensure continued stability. For symptomatic infants presenting with blood glucose less than 40 milligram per deciliter, immediate and decisive intervention with intravenous glucose is required. If the blood glucose is critically low, specifically less than 25 milligram per deciliter, a rapid bolus of intravenous dextrose 10% should be administered at a dose of 1 to 2 ml per kg. This bolus must then be followed immediately by a continuous intravenous infusion starting at a rate of 5 to 8 mg per kg per minute to sustain glucose levels. The primary goal during this acute management phase is to rapidly achieve and maintain plasma glucose levels greater than 50 mg per deciliter. During this process, continue to encourage frequent breastfeeding if tolerated and recheck plasma glucose within 30 minutes of initiating or adjusting therapy. When setting up the initial parenteral therapy, a graded approach to the glucose infusion rate is employed tailored to the infant's specific risk factors. For infants with intrauterine growth restriction, a rate of 5 to 7 mg per kg per minute is often appropriate. For infants of diabetic mothers and large for gestational age, a slightly lower starting rate of 3 to 5 mg per kg per minute may be considered due to their tendency for hyperinsulinemia. And for other at-risk groups, a general range of 4 to 6 mg per kg per minute is typically used. This tailored rate helps optimize glucose delivery while minimizing the risk of rebound hyper or hypoglycemia. If an infant requires a glucose infusion rate that exceeds 12 mg per kg per minute, this is a significant indicator that warrants a consideration for further intervention and more thorough investigation into the underlying cause of their persistent hypoglycemia. This high requirement often suggests a more complex etiology than transient physiological adaptation. It's also crucial to adhere to guidelines regarding maximum dextrose concentration that can be safely administered to prevent complications like extravasation or sclerosis of veins. Through a peripheral IV cannula, the maximum dextrose concentration is typically 12.5%. However, if higher concentration are necessary, such as up to 25%, a central venous catheter must be utilized. Continuous and vigilant monitoring of blood glucose levels is paramount throughout parenteral therapy. This involves regular rechecks until at least 3 consecutive normal glucose levels are achieved, ensuring sustained stability and effective management of the condition before considering de-escalation of therapy. The potential deleterious effects of hypoglycemia on the developing neonatal brain are major concern, making it imperative to manage this condition effectively. It is strongly recommended to treat symptomatic hypoglycemia and to actively prevent recurrent and persistent hypoglycemic episodes due to their established association with seizures and subsequent impairments in visual motor and executive function observed in children at 4 to 5 years of age. For asymptomatic hypoglycemia, while the evidence base is less clear, there are still significant concerns among clinicians. These include potential links to poorer literacy scores and reduced visual motor and executive function, particularly with recurrent or severe episodes, even if initially asymptomatic. The risk appears to be cumulative. Furthermore, in preterm neonates, specific associations have been reported between the recurrent low sugars and low Bailey scores, which are developmental assessment tools, as well as broader developmental and cognitive delays. Given these findings, it is evident that more dedicated research is urgently needed in this vulnerable group of preterm neonates to fully understand and mitigate the long-term neurodevelopmental impacts. Finally, let's discuss the essential criteria for safely discharging an infant who has been managed for neonatal hypoglycemia. For an infant who has experienced persistent hypoglycemia, defined as lasting more than 72 hours, or who required intravenous therapy for either symptomatic or asymptomatic low glucose levels, the discharge criterion is stringent. Such as an infant should only be discharged from the hospital if their blood glucose levels can be consistently maintained above 17 mg per deciliter through several consecutive feed-fast cycles. This critical requirement ensures that the infant has demonstrated the physiological capacity to manage their own glucose homeostasis without medical intervention, reducing the risk of recurrence once they return home. It verifies that the infant can maintain adequate glucose levels during typical feeding intervals, providing reassurance for safe transition to home care. Thank you for your dedicated attention to this critical and vital topic. I strongly encourage all of you to practice and integrate this information into your daily interactions. If you have any further questions or require additional clarification, please feel free to reach out to me in the comments and also on Instagram. And please like, share, and subscribe to the Docsaab's Diary.